Listo. Bueno, entonces ahora sí vamos a seguir. Nuevamente, perdón, disculpas por estas fallas técnicas, pero bueno, aquí viene la parte más importante. Listo, entonces básicamente lo que le estaba contando es que esta va a ser una serie de charlas. Esperemos que a futuro se puedan programar más y básicamente el enfoque va a ser este. Entonces vamos a empezar con esto. Lo primero, the medical history and epidemiology for the traveler. Entonces, tenemos que los viajeros son precisamente las personas con mayor probabilidad de sufrir en el destino e importar enfermedades agudas contra las cuales, pues a diferencia de los residentes del área como tal, ellos no tienen inmunidad. ¿Listo? Lo mismo ocurre con los inmigrantes que regresan a su país de origen, que después de un largo periodo de ausencia pierden esa semi-inmunidad que ya habían adquirido después de muchos años en el mismo ambiente. ¿Listo? Entonces, tenemos como tal unos factores de riesgo para, como tal, para adquirir cualquier tipo de enfermedad, sobre todo de origen infecciosa, en los viajes internacionales y sobre todo son los que son mayores a 30 días, las que tienen que ver con actividades del cuidado de la salud, la presencia o viajar a zonas endémicas, viajar a zonas desoladas o rurales y áreas que tengan pues una inestabilidad social. ¿Vale? Y los riesgos para los viajeros internacionales, es decir, para nosotros, los que salimos y emigramos, va a ser para los viajeros menores de 5 años y mayores de 65 años, personas que sufran de enfermedades crónicas no transmisibles, entonces aquí dentro de este grupo pues encajamos diabetes, hipertensión y demás, pacientes que tengan inmunosupresión o que no tengan un antecedente de vacunación completo. Siguiente. Entonces, medical history and epidemiology. Okay, so for this part, I will try to speak in English and then I will translate for you. All right. So some medical features in the approach of any patient that might have special relevance may be. So at first, we gotta talk about the name. So the name, especially in our country in Colombia, I don't know if there are any listeners who are from other countries, but for Colombia, we'd have both last names, one from our father and one for our mother. And in case we have like both last names, if they are the same, there is a higher risk we have consanguinity. Entonces, básicamente lo que tenemos es que si somos una persona que tiene los dos apellidos iguales, es probable que podamos aumentar el riesgo de que haya cosanguinidad y esto pues sabemos que nos va a predisponer a muchísimas enfermedades, sobre todo del tipo autosómico recesivo. ¿Listo? Obviamente no se pueden hacer suposiciones antes de tiempo, pero pues es una posibilidad que podemos considerar solamente con el nombre. So, as soon as I show you this picture of a sickle cell, you already know that we are talking about sickle cell disease um, and other autosomal recessive diseases such as cystic fibrosis, Tay-Sachs disease. So it is very important to remember also in this pathology that sickle cell disease occurs in one over 365 African Americans. So the race plays a major role too. Um, entonces, traduzco. Para la parte de aquí el nombre también tener en cuenta como con la cosanguinidad, saber que tenemos predisposiciones importantes de padecer de anemia de células falciformes, que sabemos que es una enfermedad sobre todo autosómica recesiva, en la que principalmente son los afroamericanos los principales afectados. ¿Listo? Como otro factor importante tenemos la edad, sabemos que a mayor edad aumentamos el riesgo de enfermedades crónicas. Otros riesgos van a incluir el tipo de trabajo, la exposición laboral. So, okay, I will try to say in English. Um,
Oye,
¿Aló?
ahora un segundo. al caerse el anterior directo, entonces se genera un nuevo link. En este link es el que vamos a estar compartiendo. Entonces vamos a esperar unos minutos para que se una la gente que estaba en el otro que se cayó. Listo, ya vamos a reactivar de nuevo la charla en donde quedó. Eh, Damos el paso entonces a Nicolás.
So, okay, as I was saying, another factor that we need to take in mind is the age. So we know that the greater the age, we have a greater risk of developing chronic diseases. Another risk is the occupational risk, in which probably we wouldn't think of some diseases here in Colombia, but we know that if a person comes from another country, he might have diseases such as, um, for example, I'll try to speak only about occupational risk. So, um, let's say forest rangers or vets, entonces los guardabosques o los veterinarios, sobre todo en los parques nacionales en Estados Unidos, tienen un riesgo incrementado de presentar patologías que pues no son muy frecuentes en nuestro medio y que muy probablemente iremos a confundir o no las pensaremos si no las conocemos. Dentro de estas, pues podemos encontrar la tularemia, la enfermedad de montañas rocosas, la enfermedad de Lyme y otras enfermedades relacionadas con las mordeduras de artrópodos como las garrapatas. ¿Listo? Eh, Otro factor importante va a ser la nacionalidad, y es que podemos tener casos, por ejemplo, en el que si les presento un caso, tenemos un paciente de 14 años que ingresa a sala de urgencias con dolor abdominal severo, que tiene un Blomberg y un Roxing positivo, que tiene fiebre de un día de evolución. Lo primero que uno piensa, pues inmediatamente va a ser una apendicitis, ¿cierto? Seguramente también, bueno, si es una mujer, podemos considerar una torsión ovárica, incluso si estamos en un rural, en esas regiones alejadas del país, podemos pensar en una ascariasis o una obstrucción intestinal. Sin embargo, eh, pues nunca vamos a pensar, por ejemplo, en la fiebre mediterránea familiar. Y es por esto que es importante ese antecedente de la nacionalidad del paciente. Recordemos que la fiebre mediterránea familiar es una enfermedad que tiene particular prevalencia en el litoral, qué pena, mediterráneo, particularmente en lo que es Arabia, Turquía, y que afecta más o menos a uno de cada 200 a 1000 personas en esta población. Entonces, digamos que allá muy probablemente se tienen todos los protocolos para el diagnóstico de los pacientes con fiebre mediterránea familiar, y claramente acá no los tenemos. Es importante saber que pues, la clínica de esos pacientes puede llegar a ser pues, muy similar a un cuadro agudo abdominal, y tener en cuenta también que si no lo diagnosticamos, con el tiempo podemos llegar a tener pues, una de las complicaciones, como puede ser la amiloidosis. Como tal, dentro de la residencia, el país de residencia, pues digamos que también va a ser muy importante, ahí junto también con la nacionalidad, sobre todo, eso ya sería un ejemplo más para nosotros colombianos saliendo a otros lugares del mundo. En nuestro medio es frecuente que nosotros tengamos la vacuna contra la tuberculosis, y sabemos que esta vacuna nos va a dar una prueba de tuberculina positiva, nos va a dar un falso positivo, que es, digamos que una prueba diagnóstica o inicial de sospecha de tuberculosis en otros países, y va a ser pues otro factor a tener en cuenta. Siguiente. Listo, esta es una frase de Martin Luther King. Martin Luther King fue un activista americano, estadounidense, abolicionista, y Pues digamos que lo traje principalmente porque con esta charla busco también que todos nos sensibilicemos. Vas a la siguiente, por favor. Nuevamente quería presentar estas imágenes eh, para recordar pues, toda la problemática que estamos viviendo actualmente, que son temas de no dejar pasar y temas de los que nosotros como médicos y que personas que nos formamos de forma integral tenemos que estar al día. Listo, puede que con el tiempo manifestemos menos la tristeza, pero pues tengan presente que por más fríos no podemos dejar de ser humanos. Listo, entonces una invitación para sensibilizarnos. Next, I will give the word to my dear friend James. So James and I were close friends in middle school. We graduated from the same middle school in the U.S. So go ahead, James. Thank you very much for coming. I really appreciate it, man. Um, Go ahead.
All right. Hola, buenas noches. Mi nombre es James Amanonce. Hi, everyone. My name is James Amanonce. Like Nicholas said, we're close friends. We both attended the same middle and high school. And I graduated from New Jersey City University and obtained my Bachelor's of Arts with a major in psychology and a minor in business administration. Today, Nicholas asked me to explain to you guys how to present bad news to patients. And breaking bad news is not an easy task. But as healthcare professionals and practitioners in the medical field, it is important for all of you to have the ability to effectively deliver bad news to your patients. Now, before I get into the Spikes protocol, which is on the screen, I want you guys to think about this. A young girl asks you, her doctor, "Doctor, why do I feel so bad?" And as her doctor, you know that she is suffering from cancer, and you've grown emotionally attached to her. How do you tell her parents that she has cancer? And then how do you tell her that she has cancer? So just think about that as I go through the Spikes protocol and think of ways that you would approach this situation. Nicholas told me that in Colombia that sending bad news is usually used by the Spikes protocol, and I'm sure that you guys are all aware of Spikes protocol. And I believe that following these guidelines are very helpful and useful in helping you accomplish that task of giving bad news. So let's go over those steps and go into further detail. So step 1, which is S, is setting up the interview. When you have to present bad news, it is a good idea to arrange for some privacy. Just like when you go to a doctor's office for a checkup, or like as psychologists, we like to have therapy sessions one-on-one with our patient because it allows them to have some privacy and they're allowed to be comfortable, that they're sharing this empty space with us and it's just them and us. There's no barrier in between us. So for you guys, an interview room is ideal, like an office, but if one's not available and you're around the patient's bed, you can draw the curtains around to get some privacy. And also you should have some tissues ready in case the patient becomes visibly upset. You want to make sure that you remove all distractions from the environment, any external noises such as like electronics, TVs, your phone, if you can, possibly outside noise, anything that could disrupt or interrupt the conversation between you and your patient. You also want to manage time constraints and interruptions. You want to inform the patient of any time constraints that you may have or interruptions that you are expecting. But assure them that the time with them now is your main priority at the moment. And however, there might be emergencies that you have to attend to, but again, reassure them that this time is their time. Also, you should wear a watch that's useful or have a clock in the room so that you can see whether or not you're going over your time limit or under your time, or that you're just talking and you're not getting anywhere. And also have your colleagues respond to any messages that go to you so that when you're done with your meeting and the discussion, you can get informed and updated for what's going on and anything else that you need to attend to. Also, for setting up the interview, you want to involve significant others. It's important for patients to have someone close to them. You know, but it should be the patient's choice. It shouldn't be someone that they don't want there. And if there are too many people in the room with the patient, you should ask the patient to choose 1 or 2 representatives that they would like to have with them. Next, you should also sit down Sitting down relaxes the patient, and it's a sign that you're not in a rush or will rush. When you sit, like I said earlier, try not to have barriers between you and your patients. You don't want folders, you don't want anything obstructing your view from them and their view from you. And also, if you have recently examined the patient, allow them to dress before you speak to them. The reason why you should sit down and have this one-on-one conversation is that it shows them that you're paying attention and that you're giving them your attention, just like the way psychologists do with therapy. And we don't stand up, we don't walk around, we sit down, we face the patient, we maintain eye contact, and we give them the impression, or not the impression, but we are showing them that we're paying attention to them. You want to make the connection with the patient. However, you don't want to make a emotional or personal connection with them. You don't want to get attached, but you do need to create a communication connection. And you should be able to understand how to convey your message. You should be aware of your tone, and you should understand their perceptions and emotions due to the current situation that they're in. And earlier I said again, like maintaining eye contact. It could be uncomfortable sometimes, but that's how you develop a connection between you and your patient. Also, some type of contact is another way of connecting with them, like a light touch on the patient's arm, shoulder, or hand, only if they are comfortable with it. Now, step 2, which is P, is assessing the patient's perception. Before discussing the medical findings, you should use open-ended questions to create a reasonably accurate picture of how the patient perceives the medical situation, what it is, and whether it is serious or not. Based on this information, you can correct the misinformation and tailor the bad news to what the patient understands. So if they hear that it's this extreme, you can clarify and tell them, no, that's not the situation, that's not what's happening, and you tell them the correct information. It can also accomplish the important task of determining if the patient is engaging in any variation of illness denial, wishful thinking, omission of essential but unfavorable details of the illness, or unrealistic expectations of treatments. And after that, which is step 3, it's I, which is obtaining the patient's invitation. Majority of patients express a desire for full information about their diagnosis, prognosis, details of their illness, while some do not. When a clinician hears a patient express explicit desire for information, it may lessen their anxiety with divulging the bad news. However, shunning information is a valid psychological coping mechanism and may be more likely to be manifested as the illness becomes more severe. So when patients, when they're receiving bad news or when they don't want to take the bad news, they might avoid hearing what you have to say. And that's because that's how people deal with things. That's how they cope with certain situations. That's how they're going to deal with the situation. They want to avoid the bad news because generally we don't like hearing bad news as people. And then you should also discuss information disclosure with the patient, get any legal terms, anything. You should disclaim what you need to do as their doctor so that you can't be held for any malpractice or you can't be sued in return if you didn't claim anything. Examples of questions that a patient would ask would be, how would you like me to give the information about the test results? Would you like me to give you all the information or sketch out all the results and spend more time discussing the treatment plan? If patients do not want to know the details, offer to answer any questions that they may have in the future or talk to a relative or friend, because sometimes they may not want to hear from you, but if you can get that information out to someone close to them that they feel comfortable with, they may understand, and then they'll come to their senses, and then they'll come back to you, and they'll be able to discuss those things with you. After obtaining the patient's invitation, it's step 4, which is K, and that's giving knowledge and information to the patient. You want to be giving medical facts. A one-way part of the physician-patient dialogue may be improved by a few simple guidelines. First, you want to start at the level of comprehension and vocabulary of the patient. This is really important because if you're working in a hospital, if you're a doctor, no two patients are alike. No one is the same. People come from different backgrounds. They all come from different socioeconomic statuses. and different life experiences. And it's important to know where they stand with their education level, their comprehension and vocabulary, because that's going to determine and translate into how you speak to the patients and communicate to them. Second, you want to try to use non-technical words such as spread instead of metastasize and sample of tissue instead of biopsy. Because if you're talking to someone that doesn't know anything about medical terms, technical terms, they will not have a clue what you're saying. So what you need to do is explain it to them or define it into a word that they will understand. Third, you want to avoid excessive bluntness. And I highly emphasize this point because an example of this, of being blunt, would be you have very bad cancer, and unless you get treatment immediately, you're going to die. Yes, that's very straightforward and honest with the patient, but the way it's delivered, it's not effective, and the patient may react in a very negative way because you just said you have very bad cancer. Unless you get treatment immediately, you're going to die. This will most likely leave the patient isolated and later angry, with the tendency to blame the messenger of the bad news, you. See, there's a difference between being honest and being blunt. And being blunt is like you're not being empathetic, and later on I'll get to that point. But fourth, you want to give information in small chunks and check periodically as to the patient's understanding. You don't want to deliver an abundant amount of information to the patient and overwhelm them with it. Instead, you want to start like just small details, clarify little things, give into it bit by bit, make sure that they're understanding what you're saying, and you gradually increase the information that you're delivering to the patients. Fifth, when the prognosis is poor, you want to avoid using phrases as "there's nothing more we can do for you." That attitude is inconsistent with the fact that the patients often have other important therapeutic goals, such as good pain control and symptom relief. Yes, cancer is really bad, but that doesn't mean that's the end of it. There are other ways for them to relieve their anxiety, their emotions, and the pain that's going to be caused to them. So just because if you can't find a cure for their disease, you should find other ways to help aid them in surviving or not surviving, just dealing with the illness. Like I said, if there's no cure, that does not mean you're unable to do anything or help them at all. There are other ways of aiding and assisting the patient during these tough times, and that you should do what you can to the best of your ability and to the resources that are available. And step 5, E, is addressing the patient's emotions with empathetic responses. And having empathy, this will really help you in delivering bad news to patients, because empathy is an important ability to have because you're able to understand and share the feelings of another person, compared to sympathy, which is only having feelings of pity and sorrow for someone else's misfortune. Think of having empathy as being able to put yourself in their shoes. You're in their position. You're experiencing what they are in that situation. You know their feelings. And then compared to sympathy is just saying, "Oh, I'm so sorry, I feel bad." Empathy is you're really experiencing what that person is experiencing. And having let's see. And I think some doctors, I think this is where bad news is really affects the patient, is that I think a lot of people lack empathy, and it's because doctors are there to do their job and diagnose you and give you treatment and do what they're supposed to do, but they're not trying to develop an emotional connection or relationship with you, because if they're close to you, it might affect their mental health, because they're able to see that you're negatively affected and that your emotions are overwhelming. Your situation's not the best. You don't want anyone to experience what they're experiencing, so that they probably just cut that emotional tie off and deliver that news. However, the patient is affected because of that and because they lack empathy. And it's hard to have empathy sometimes because it's difficult to respond to the patient's emotion, and that's one of the most difficult tasks of breaking bad news. And earlier I said again, all patients are not the same. You can't treat one patient the same as another. You can't come with the same approach towards another patient the way you did to a previous. You can't use the same approach for everybody. Their emotional reactions may vary from silence to disbelief, crying, denial, or anger, and so on. They all had different experiences. They all came from different backgrounds. The way you may speak to them, they could interpret it the wrong way. And then when patients also get their bad news, their emotional reaction is often an expression of shock, isolation, and grief. In this situation, you can offer support and solidarity to the patient by making empathetic responses. An empathetic response consists of 4 steps. You want to observe for any emotion on part of the patient. It could be tearfulness, a look of sadness, silence, or shock. Body language is important to look at, and it's something that will help you distinguishing their feelings in response. If you see that the patient's eyes are moving side to side, that could be them being anxious, their legs shaking, their head down. Those are all signs of different emotions and their reactions and their expressions. You then identify the emotional experience by the patient by naming it to oneself. If the patient appears sad but is silent, use open questions to query the patient as to what they're thinking or feeling. If they look sad but they're silent, you want to figure out what's going on. You want to know what they're feeling. You want to understand what they're going through. And then you identify the reason for the emotion, and this is usually connected to the bad news. They wouldn't react this way if it wasn't for the bad news. However, if you're not sure, you ask the patient because only they know how they're feeling and they know the reason behind their emotions. And another part is that after you have given the patient a brief period of time to express his or her feelings, you let the patient know that you have connected the emotion with their reasoning. You want the patient to express those emotions, whether they're angry, whether they're upset, they're sad, they're anxious. You want them to experience that emotion because it's fair to them and it's valid for them to experience these feelings because of what's happening. An example of this conversation, you could probably go, the doctor would say, "I'm sorry to say that the x-ray shows that the chemotherapy doesn't seem to be working. Unfortunately, the tumor has grown somewhat." And the patient could respond, "I've been afraid of this," and then they start crying. The doctor, you can move your chair closer, you stand up, you stand by their side, you offer them a tissue, you wait, you let them express that, and then you could say, "I know that this is what you wanted to hear, and I wish the news were better." So what you're essentially telling the patient is that you know that the treatment's not getting better, and the patient was worried about this. You get closer, you provide comfort, you show them that you do care, that you're there for them, and that you connected with them, and that you're feeling their emotions, and that you wish that, like they wish, that the news were better. The physician observed the patient crying and realized that the patient was fearful because of the bad news. You just want to let the patient understand that they were upset by making a statement and that it reflected in their understanding. So until an emotion is cleared, it will be difficult to go on to discuss other issues. If the emotion does not diminish shortly, it is helpful to continue to make empathetic responses until the patient becomes calm, because you don't want it to extend or prolong. Clinicians can also use empathetic responses to acknowledge their own sadness or other emotions. For example, "I also wish the news were better." It can be a show of support to follow the empathetic response with a validating statement, which lets the patient know that their feelings are legitimate. Again, when emotions are clearly not expressed, such as when the patient is silenced, the physician should ask an exploratory question before he makes an empathetic response. When emotions are subtle or indirectly expressed or disguised as a thinly veiled disappointment or anger, you can still use an empathetic response. And then the last step for the SPIKES protocol is strategy and summary. Patients who have a clear plan for the future are less likely to feel anxious and uncertain. Before discussing a treatment plan, it is important to ask the patients if they are ready at that time for such a discussion. You want to ask that because you just explained to them the bad news. And that may be a lot for them to take in. They're, again, overwhelmed with a lot of emotion and then with the information that they just received. So presenting a treatment options to patients when they are available is not only a legal mandate in some cases, but it will establish the perception that the physician regards their wishes as important. Sharing responsibility for decision-making with the patient may also reduce any sense of failure on the part of the physician when treatment is not successful. Checking the patient's misunderstanding of the discussion can prevent the documented tendency of patients to overestimate the efficacy or misunderstand the purpose of treatment. Clinicians are often very uncomfortable when they may discuss prognosis and treatment options with the patients if the information is unfavorable. Because you just told bad news, you might not want to tell them more bad news as to how they're going to treat their illness. Based on our own observations and those of others, we believe that discomfort is based on a number of concerns that the physicians experience. These include uncertainty about the patient's expectations, fear of destroying the patient's hope, fear of their own inadequacy in the face of uncontrollable disease, not feeling prepared to manage the patient's anticipated emotional reactions, and sometimes embarrassment and having previously painted too optimistic a picture for the patient. These difficult decisions can be greatly facilitated by using several strategies. First, many patients already have some idea of the seriousness of their illness and of the limitations of treatment, but are afraid to bring it up or ask about outcomes. Again, exploring the patient's knowledge, expectations, and hopes will allow the physician to understand where the patient is and to start the discussion from that point. When patients have unrealistic expectations, for example, they told me that you will work miracles, asking the patient to describe the history of the illness will usually reveal fears, concerns, and emotions that lie behind the expectation. Patients may see cure as a global solution to several different problems that are significant for them. These may include a loss of job, inability to take care of the family, pain and suffering, hardship on others, or impaired mobility. Expressing these fears and concerns will often allow the patient to acknowledge the seriousness of their condition. If patients become emotionally upset in discussing their concerns, it would be appropriate to use the strategic outline steps in step 5 of spikes. Second, understanding the important specific goals that many patients have, such as symptom control, and making sure that they receive the best possible treatment and continuity of their care will allow physicians to frame hope in terms of what is possible to accomplish. This can be very reassuring to patients. I believe that the protocol is very useful, but using empathetic, validating, and exploring statements to respond to patients' emotions is the greatest challenge. It's because you may not know the patient personally. They might tell you about their lives from time to time, but you don't have that connection with them. It's important to develop the ability to be empathetic because you're being able to understand what it's like to be that person, even though you don't have that disease, their illness, you're not suffering from their hardship. A good way to practice this is role-playing. It's a great way to gain experience and increase your confidence. Also, teaching and explaining it will further develop your ability to formulate a plan and be confident when you do have to break bad news. As doctors, you do have to be prepared mentally and physically because you might be working long hours, life doesn't go the way you wanted to go. There are other external factors that may contribute to your emotions. You may be upset that day. You probably didn't sleep well the night before. You got into an argument with a friend, a family member. You didn't eat breakfast. You're hungry. There are other things that are happening and that can contribute to other factors of breaking bad news. You shouldn't let your emotions take over you. You may feel that sometimes doctors deliver the news bluntly and just straightforward, and they feel that's the best way to do it. But their perception and the patient's perception are completely different, and it's important to get both of your perceptions on the same page so that both parties understand and interpret messages the way they were intended to be. One of the things I believe to be factual is to always be empathetic and non-judgmental. It's important to be optimistic, but do not promise something that may not be delivered. Prior to breaking bad news, though, ensure that you have, just going over these points, just making sure, and going over the overview, is that you don't want to have your phone ringing. You want your phone undivided attention. Do what you feel is right for that person at that time. If you haven't experienced therapy, I think that will definitely help you in understanding patients and how to speak to them, because I think therapy is a good experience for doctors to be able to speak to people and then also understand and listen to them and then express yourself in a way. And also, when you deliver bad news, I would say you should think of it like this. Personally, what you want to have said, what you have said to them, you feel as you develop a better communication style because you're connecting it to your personal life. You're thinking about other people. You're relating it to people that really mean to you. You communicate to them in certain different ways, and that'll really help in breaking bad news to patients. Also, like I said earlier, you want to take your patient's education level into consideration. You want to observe their body language. You want to see the person, how they are coping, and offer them a few words of empathy. Another point to touch on is children, because adults aren't the only patients that you'll be breaking bad news to. For like a medical diagnosis such as cancer, children will need to understand what will happen each step of the way, with information given close to the actual experience to prevent unnecessary worries or fears. Age appropriateness is important. Young children should understand if a medicine will make them sick or cause their hair to fall out. Older children may want to understand their diagnosis and treatment in detail. Failure to provide children with this information can be traumatizing. Also, if a parent does not inform their child, not only will the child become fearful, but the parent may lose their child's trust, as the children may begin to wonder what else their parents are keeping with them. And the same thing with the doctors, that they're there for your information, and that if you're withholding information with them, they will feel like you're not telling them the truth or that you're really hiding something. Also, because they are minors, the parents their parents' decisions are important. Decisions are made by the parents until they're 18, so it's in the best interest of the parents. You also, just basically, honesty is key, but you don't want to be blunt. You need to tell them what they need to know. And if you aren't sure if they understood, you want to ask them, and you want to repeat it, and you want them to repeat it back to you so that you can correct any misinformation. You also should be prepared to answer questions and provide additional age-appropriate information. You want to continue and check in with the child to see how they're processing the news and help them overcome any hurdles that they may have to learning about and understanding the bad news. Research shows that withholding information may result in children's imagining a worst case scenario. And the same thing with older patients, that if you're withholding information, they might imagine the scenario to be worse than it actually is. But back to children, without understanding they feel bad, the child may begin to discern their own explanation for the secrecy, including they might think that the illness or treatment is a form of punishment. Children are not aware of their diagnosis, and they do not experience any less stress and anxiety when they are told about their life-threatening illness, but in some cases, they actually experience more. Openness, by contrast, appears to contribute to long-term adjustment. Practically speaking, not understanding a diagnosis may also prevent compliance with treatment recommendations, particularly in older children. So the question I asked earlier, there's an article where a doctor had a patient who was 9 years old, and the patient asked the question, "Doctor, why do I feel so bad?" And the doctor had grown emotionally attached to the patient. So the doctor's desire to protect Jill from no knowledge of her own mortality is understandable. You know, it's a kid. You don't really want to break that kind of news to them, particularly given, and it's also saying in the article that the doctor had a friend who died of cancer. You know, this experience, her age, her developmental status, and impact of this information may have on her health should all be factors influencing in how and even when the diagnosis is disclosed. However, these factors do not justify withholding the diagnosis from the child. Ultimately, the doctor's obligations to Jill outweigh the patient's parents' desire to protect her from the knowledge of her life-threatening illness. You know, the parents may say, "Doctor, we don't want to tell her. We can't. I don't think we should say that to her." The doctor's concern for the patient outweighs the patient's concern for their child, because the child has to know what's happening. What else? Let's see. But like again, the doctor has a legal obligation to offer the 9-year-old to tell her the truth and assess whether the patient wants to know the diagnosis and how she wants to know it. Also, there could be 3 options as how the doctor presents this information. It could be to Jill's the patient's parents alone, or the doctor tells the patient's parents alone. The doctor tells the patient alone. The doctor tells the patient's parents alone, or the doctor tells the patient's parents and the patients at the same time. Some other key factors and important things to take note of is that you want to collect the dots before you connect the dots. And just because you have an initial statement or test results, that may not be the whole picture. So you want to make sure that you have all the information you need before you give it out and tell the patient what's happening. When you find out about the certain news, you yourself, you need to prepare. You need to gather all the information you can before you come to any conclusion and plan how you break the information. As doctors, your job descriptions don't label psychologists or therapists. I don't think you would have any of that training unless you've attended some classes. But as doctors, you're there to help your patients. But as human beings, there's no cost to consider the patient's feelings. Again, you don't want to let your emotions take over you and deliver the news in a bad way. You want to be transparent and factual with their conditions and symptoms and what they're dealing with. You don't want to sugarcoat certain possibilities. Again, earlier I mentioned, would you tell a stranger the news the same way you tell a family member, a friend, or someone? And when you're working in the hospital or as a doctor, do certain people get special treatment, or does everyone get the same thing? And that's the thing, is that no one gets special treatment and no one gets the same thing, because not everybody is built alike. No one, like again, experience is different. Their emotions, their background, their social economic status, it's all different. So you have to be able to adapt and tailor the news towards your patients depending on who they are. And again, it's within the best interest of the patient. Another keynote to think about is when delivering bad news is that you've studied and you went to school and you've worked hard for this to help people, and you're going to obviously deal with people, but you are human and you are doing the best that you can, and that's okay. It's okay to tell the truth, even if it hurts. It's okay that sometimes you mess up delivering bad news the first time. You can mess up again, and that's okay. You can't beat yourself up about it. You just gradually gain experience and you learn from your mistakes. And the more you withhold information and the more you don't deliver bad news and if you're not transparent, open, and blunt to them, you do more harm to yourself than you do to them. You should also remember your patients by their names and not their conditions. And on the presentation, there's a slide which has empathetic responses that you guys can look at. And I just one more thing, I guess, to kind of summarize and conclude is that, again, be clear and concise to minimize the chances of confusion or back and forth communication. Make sure that they interpret the message the way you intended it. You want to help the receiver understand and accept the news. You want to reduce the anxiety associated with the negative news to increase comprehension. You want to maintain trust and respect for the business or organization and for the receiver, like the hospital. You don't want the hospital to have a bad reputation. You don't want your department, you as a doctor, you don't want bad reputation because you messed up or you delivered news the wrong way. Patients might not feel comfortable around you. You want to avoid, wrong admission of guilt or feeling responsibility for being wrong or at fault. And lastly, is just maintaining the relationship between you and the patient, because if you're going to be treating them for however long, you want them to know that you still care, but you can't be emotionally attached because it might be detrimental to your mental health. And, it's delivering bad news it's in a gray area, such as with psychology and like therapists, that there are some ethics that we have to follow and guidelines that we have to follow. And there's like legality that we need to keep up with. But as doctors, there is no definite answer as to how to deliver bad news. It's all different with each patient, and it's going to be difficult. But the more you experience it, the more you work with patients, and the more you learn to be empathetic and understand people, the more understanding of yourself and whether or not you want to grow or not, you'll be able to deliver bad news effectively to different patients, whether or not you know them or you don't. I think I touched on all of the points. I think that's it. Any questions, concerns, or thoughts?
Okay, Nicolás.
¿Me escuchan? Listo. Entonces, bueno, ya para finalizar, yo quería, digamos, que contextualizar todo lo que nos habló James. Yo creo que realmente la presentación fue muy completa. Entonces, pues, digamos que algunas cosas para llevar a la casa es que a la hora de informar malas noticias, conviene estar principalmente en un ambiente adecuado, no tener prisas, no tener interrupciones, tener la privacidad donde el enfermo y los familiares se puedan expresar libremente y dejar salir literalmente sus emociones. Entonces, dar malas noticias es un acto médico y también es un arte que tiene que ser aprendido, como venía diciendo James al final, y para eso no existe una fórmula ni un protocolo rígido, sino que cada persona tiene su estilo. ¿Listo? Entonces, no hay que informar al enfermo de su diagnóstico y pronóstico solo porque nos obliga la ley, sino porque es un compromiso profesional, ético y humano del médico. Vale, muchas gracias. Vamos a pasar entonces contigo, Mariana.
Entonces tenemos que, ¿cómo se llama la app de hacer las fichas?
Esta pregunta es para mí. La aplicación se llama Anki. Lo pueden buscar como anki.web. Ahí les aparece. Es súper buena. A-N-K-I. Latina. Anki.
Ok. Esta pregunta es para James, pero pues pueden responderlo los dos si quieren. Why should we limit companions up to 2?
Generally, so think of it as that you're not dealing with patients or bad news. When you want to express your feelings towards someone or you want to get advice, you want to be able to speak to you don't want a lot of people to know. You kind of want to go to your most trusted sources. Like, for example, if you're having this is off topic, but like if you have issues with a friend or a family member or current situation or like say relationship issues, you're not going to go to your whole family to be like, what's going on with us? Is this bad? You kind of want to go to that one trusted or two trusted, reliable sources. You want to be around people you're comfortable with, that you can trust, and that they're able to feel that emotion with you because you're close and you're comfortable with them. If you have a lot of people aware, it probably might be overwhelming. You're going to be very worried about everyone else that knows about your situation. Just like with therapy, if if you go to couples therapy, you're not going with your family, you're going with another person. Uh, if that makes any sense, I'm not sure. But just having one or two people that really like are significant and mean a lot to you, having that emotional support and having them in your presence will definitely make you feel at ease and more comfortable.
Entonces, aquí como también para contextualizar, pues recordar que cuando nosotros estamos dando una mala noticia, básicamente lo que queremos es que el paciente se sienta bien, que el paciente se sienta en confianza. Y como decía James, las personas a las que va a necesitar al lado no van a ser pronto el primo o la tía lejana, sino de verdad las personas de confianza, que son los que le van a dar el soporte emocional, va a ser el refugio en el que él se va a sentir seguro y en el que muy seguramente va a adoptar de una mejor manera esa mala noticia, porque precisamente se va a sentir importante. ¿Listo?
Listo, muchas gracias. En otra pregunta tenemos, how can I be sure I'm not crossing the line between empathy and pity?
Okay, so pity is the feeling of sorrow and compassion caused by the suffering and misfortunes of others. So like pity is more of a, like I pity them, like, oh, I feel bad for them. And empathy is really putting yourself in that person's position. Pity is like sympathy. It's like you're just feeling, like when you see on the news, like, oh, like say example, like a country goes through a hurricane or a natural disaster, you say, oh, I feel really bad for them. Like, they're going through a tough time. Whereas empathy is that you're experiencing what they're experiencing. You're thinking about what it's like be in that situation. You really understand that even though it's not happening to you, you're able to understand that their emotions, their feelings are valid, that it's something tough to go through, but you really understand what they're going. You can really feel for them and understand what it's like to experience that, even though you're not experiencing it yourself. I'm not sure if that really clarified. If you want, can you ask another question so I can make sure I'm getting the message delivered to you?
Sí, o sea, yo creo que la respuesta de James pues está bien. O sea, para complementar, pues es importante tener en cuenta que precisamente por esto es que las malas noticias no las da, no las da el psicólogo, no las da el médico que está de ronda, el interno, no, las da el médico tratante, el médico que acompañó a ese paciente desde el inicio de su enfermedad hasta el momento del diagnóstico. ¿Por qué? Porque esa persona es la que conoce en el mejor de los casos los antecedentes del paciente, ya sabe ese mismo paciente cuál es su núcleo familiar, más o menos cuál es la relación que esa persona tiene con ellos. Y digamos que ese médico que ya conoce la dimensión o alguna de las dimensiones de ese paciente es el que va a tener la mayor oportunidad de poder impactar positivamente a la hora de soltar la bomba, por decirlo de alguna manera. ¿Listo?
Listo, gracias. Cuarta pregunta, entonces tenemos, how should I react when the Patient blames me and sadness turns into anger.
How should I react when the patient blames me and sadness turns into anger?
Yes.
It's very. Oh, am I muted? Okay. When the patient blames you or their sadness turns to anger, that's okay because again, that's their emotions and that's valid for them to feel that way because as like if you were to hear the bad news, wouldn't you feel some type of emotion? So again, you want to let the patient express that emotion and feeling, even if it's towards you, because again, you are a doctor, you went to school, you've learned about all the procedures, the treatments, and again, you're doing things to the best of your ability. And if they might say hurtful things towards you or get aggressive, again, you want to, it's okay for them to feel that way because of what they've just heard. You know, it's a life changing moment. So you want to let them experience that emotion. You shouldn't feel any, I'm not saying that you shouldn't feel any emotion, but it's not your fault because you're not the person that caused it. You're just delivering the news, but you're also helping the patient with their treatment. You're not, you shouldn't, you shouldn't react towards that. You shouldn't portray any anger. You shouldn't be like, it's not my fault. Again, you kind of just let them experience that emotion themselves. You let them get it out. And then you say, look, I'm sorry. I know this isn't the news you wanted to hear, but this is what I can do in my position to help you. And I'm going to do the best that I can to help you. And even though you might feel this way, I'm doing the best that I can because I am your doctor and you're my patient and your best interest is my best interest.
O sea, realmente la respuesta de James fue pues, muy concreta y es lo que tenemos que hacerle saber a esas personas que pueden estar atravesando un duelo y manifestándolo en forma tanto de tristeza como de ira. Sí, yo creo que no va a ser muy frecuente que nos topemos con situaciones así si nosotros desde un principio estamos cumpliendo con nuestra ética profesional de verdad contarles a los familiares qué es lo que está pasando con esa persona cercana a la que ellos literalmente nos están confiando la vida de esa persona, ¿sí? Y yo pienso que si desde el primer momento nosotros tenemos una aproximación en el que seguimos literal pues los pasos del Spikes y nosotros mostramos empatía, le hacemos saber a la familia que estamos haciendo todo lo que está en nuestras manos para que esa persona se sienta bien, sí, le hacemos saber que nos importa que esté bien, créame que va a ser muy poco probable que nos encontremos con pacientes agresivos o con algún tipo de demandas. Si se llega a presentar el caso, como dijo James, es algo es algo que el paciente debe dejar salir y traduciendo lo que dijo James, no vamos a intentar excusarnos y empezar a refutar las acusaciones, sino más bien vamos a responder de una forma más asertiva con afirmaciones, como las que ya mencionamos. Sí, vamos a hacer todo lo posible para que esa persona esté mejor.
Bueno, yo también quería agregar de lo que yo he aprendido en la universidad, pues de pronto también se refiere a la pregunta, bueno, si esta persona intenta atacarme o algo así, ¿qué podría hacer yo? Entonces, pues unas técnicas que nos enseñaban precisamente los doctores de la universidad es que para eso es el apoyo del familiar, para que si la persona que está recibiendo la principal persona que está recibiendo la mala noticia se torna agresiva, pues el familiar pues tenga como un poquito ahí la calma de esa persona y pueda controlar la situación, porque muchas veces pues no vamos a, si estamos solos con una persona, no podríamos controlar eso y no sabríamos cómo defendernos. Entonces, pues tener claro eso, y también se refería a la pregunta a si podrían atacarnos, ¿qué podríamos hacer? Bueno, como quinta pregunta. Hearing out bad news is natural to feel overwhelmed by fear. Bueno, como quinta pregunta. Hearing out bad news It's natural to feel overwhelmed by fear. But my question is, how should the doctor deal with bad news, especially if it is a child?
Can you repeat that one more time?
How should the doctor deal with bad news, especially if it is a child?
Again, so I'm going to say that there is no right answer as to how you should feel because, again, the patients, like their emotions, their feelings, it's valid for what the news that you've delivered. But then as the doctors, your feelings and emotions, again, are also valid and legitimate because you're telling a child that like that their life might be over or their treatment's not going well, and that's very tough. And doctors, you can feel that emotion. You can again understand. You might not. Well, you can understand that what the child is going through, but you might not understand it from a child's perspective. But you should try to understand it from a child's perspective. But again, if you do feel it's okay to feel the emotions you feel if you deliver the news to a child. Um, just there's, I think that's it. Just there are other. You're not alone too. Just like the patient isn't alone in their situation. You have people that will support you as well. There are resources that are available for you, so that you don't carry that kind of guilt or burden when you've told bad news to a child. It's not your fault. Again, you're human, and that maybe you work in a hospital or an environment where you don't have the best resources available, and that's not your fault. Again, it's not your fault. None of the bad news, none of the illnesses. It's not because of you. It's just sometimes these things happen to people, and that it's not your fault. You're human, and you're doing the best that you can, and that you're doing the best that you can with the resources that you have. And I'm just going to reiterate that it's okay to feel emotions when you told the child bad news, but you have to remind yourself that it's not your fault. And then if you do feel stressed out or drained from it, then there are resources for you to, or people to speak to, that will reassure you that what you're going through is valid as well, and that the emotions that you're experiencing are legitimate. But again, it's not your fault.
James dijo algo muy importante y es que nosotros no vamos a estar solos en el servicio, o pues por lo general no vamos a estar solos en el servicio. Entonces, sobre todo el manejo con los niños, lo primero que hay que tener en cuenta es que el diagnóstico en primer lugar se discute con los padres, por obvias razones. En segundo, que cuando se trata de dar una mala noticia a un niño, se tiene que contar con todo el equipo de atención. Digamos que algunas recomendaciones que he leído sobre dar malas noticias a los niños tiene que ver sobre todo con tenerles mucha paciencia, hablarles obviamente en términos que ellos puedan entender y prepararse para una conversación que muy probablemente involucre repeticiones. ¿Sí? O sea, los niños preguntan todo el tiempo por qué y por qué y por qué y por qué. Y hay que explicarlos las veces que sean necesarios y explicarles muy bien a la familia, porque también la familia eh, es la que conoce, pues, digamos, la forma de ser del niño y con ayuda de nosotros como profesionales de la salud, explicándoles, pues, qué es lo que está pasando, van a saber aproximarse al niño y nosotros también.
Listo, esa era la última pregunta. Entonces, pues daríamos finalizado la charla de hoy. Muchísimas gracias a los dos por estar aquí, a Nicolás y a James por darnos toda esta información tan útil. Y pues esperamos podamos encontrarnos en otra ocasión para otro tema.
Thank you very much, James.
También nos pueden seguir en el...
Thank you so much for having me.
Ok, perdón. Nos pueden seguir en YouTube para estar al pendiente pues cuando tengamos otra charla. Disculpen de nuevo por todos los problemas que tuvimos en esta y esperamos que no se repitan. Gracias por acompañarnos.